All right, folks. Well, thank you for joining us for August's Central Maine Tech Night. Good afternoon for everybody that is visiting with us this afternoon. And welcome to Central Maine Growth Council's Tech Night and Network Tech Talk, albeit occurring today in the afternoon. It is wonderful to see everybody digitally this afternoon. We are being broadcasted virtually via Zoom. For those of you that have not attended in the past, Central Maine Tech Night is a monthly, typically evening event, where in our small group setting, founders and leaders share real advice on how they overcame challenges, capitalized on their target market, and developed their product, providing you with actionable insight for your own products and processes. You may find us on Facebook or online at centralmaine.org at the Tech Night tab. I would like to thank our sponsors this afternoon. This free event is presented by the Central Maine Growth Council and is sponsored by CGI, Thomas College's Harold Alfond Institute for Business Innovation, Valley Beverage, and Bricks Co-working and Innovation Space located downtown Waterville, Maine at 10 Water Street in the Hathaway Creative Center. Bricks is where we typically hold these evening events. However, as we are today, been going virtual since April. Really like to thank our awesome speakers this afternoon. As usual, you'll be able to find this video recorded for later viewing purposes online. So for folks that are watching from home at a later date, welcome to you. August's Network Tech Talk is telehealth, more than just video, Maine General's approach to virtual care, by Dr. Dionne and Laura, the Telehealth Coordinator of Maine General Health. COVID-19 has rapidly increased the demand for telehealth services across the nation as patients seek more streamlined, convenient health experiences. Maine General will share their perspective on launching telehealth services to ensure safe, high quality, and compliant care for patients of Central Maine. I'm sure many are familiar with Maine General. If you are not, Maine General Health is a comprehensive nonprofit health system in Central Maine with the mission of enhancing every day the health of patients, families, and our community. MGH delivers a range of healthcare services in a variety of care settings from birth through end of life. So thank you so much to the Maine General team for joining us. And before I toss it to them, just remind folks that are listening here live today that this is being broadcast live for later viewing. If you do have any questions or comments, as folks may know or not know, we keep this very casual and collegial. Please feel free to drop any questions or comments in the comment box. And likewise, we would ask folks to remain muted for the presentation. So without further ado, I will pass this to the Maine General team. And thank you for joining us again.
Thanks for having us, Garvin. I really appreciate it. So to reintroduce myself, I'm Andy Dionne. I'm the Chief Medical Officer for Maine General Medical Center. I've been with Maine General now for a little more than 20 years, trained as a family doctor, worked most of my career as a hospital physician, done a variety of administrative jobs, and I've been in my current role overseeing the medical center from a medical staff standpoint now for about 6 years. Certainly have had some experience with our approach to digital health and telehealth over the course of the last few years. But certainly, as Garvin mentioned, that has ramped up for us in the age of COVID-19. I'm also very happy to have Laura Mrazik here with me today because she knows much more about this than I do. And so I'll let Laura introduce herself.
Thank you. I'm Laura Mrazik. I'm the Telehealth Coordinator here at Maine General. I've been with the organization for 8 years. I have a background in public health and community health education. So I started here 8 years ago as a health educator, and then moved into some working with our insurance companies in our accountable care space, and have been in this position as Telehealth Coordinator, working kind of on the front line with folks implementing these services since end of January. So very pleased to be here. Thank you for having us.
So we can go to the next slide, Garvin. So this is a quick overview of what we'd like to talk about. Our plan is really to probably keep this presentation somewhere in the range of 20 to 30 minutes at most, to allow for some time for conversation and questions. We definitely wanted to jump into just a general overview of what is telehealth, and try to impress how for a healthcare system it is much more than just connecting patients and doctors by video. And there's a lot that goes into that. We absolutely want to touch on the COVID-19 impact and how that has really sprung forward quite a bit of the work that we're doing in telehealth, both locally at Maine General and nationally. So we'll get into some of the efforts of things that we're doing, including our Maine General eCare, our mobile patient experience, remote patient monitoring, our patient portal, which is called Follow My Health, the FMH designation there, and then some of the emerging trends overall in telehealth before we move into questions and answers. So with that, I will have you skip to the next slide, and I'll hand this over to Laura.
Great. So telehealth, what is telehealth? Telehealth is a very broad term with many definitions, which vary by payer, health system, organization really. For the purposes of today, this is a Department of Health and Human Services definition. Telehealth is using electronic information and telecommunication technologies to extend care when you and your doctor are not in the same place at the same time. So that could be a phone or video visit, sending and receiving a photo, a note or a message by email, secure email or some secure chat function. It could be remote monitoring where you're having someone from your care team, whether that's a nurse or someone else from your care team, watching your vital signs while you're in the comfort of your own home and reaching out to your primary care provider as needed. There's also provider to provider where providers in different locations are consulting each other when there's a specialist in one location and a primary care provider in a different location. So that's kind of how we're going to scope out telehealth as we talk about it today. Next slide, please. So telehealth is more than just video. What you see on the screen here is just not an exhaustive list, but a list of some of the key decision points that we make when we're rolling out a new telehealth service. This example here is some of our considerations for primary care. So there are different, not only technological requirements and considerations that need to be made, there's thought about the space where the provider or medical staff member will be sitting, where you are documenting, are you able to bill for that service? Do you need to bill insurance? Or do you bill the patient directly? A lot of workflow considerations. And the reality is we would like to keep all of those key decisions. We want to make sure we make those decisions before implementation because we'd like it to be as seamless as possible for the patient and for that patient experience to be really simplistic on their end. I know Steve Jobs has said the same thing about making Apple as simple as possible because it's very complicated on the back end, but it needs to be for it to be a simple, seamless experience for the patient. So next slide, please, and I'll hand it back over to Dr. Dionne.
Thanks, Laura. So as we mentioned, COVID-19 had a huge impact in really stimulating a lot of discussion and growth in telehealth across Maine, across New England, across the United States, and certainly across the world. And these are just a few of the areas that we wanted to touch on that have really changed in the nature of doing this. So obviously, I think as everyone knows, there is much more of a patient demand for this for these sort of services. Since the world changed for us in the end of February through March and April, when patients and families were largely staying at home all the time, there was still a need to seek healthcare. and while healthcare organizations didn't stop doing what we were doing, we still had emergency departments running, we still had surgeries, we still had people working in their offices. By and large, people were not particularly excited, whether they were sick or not, about leaving their homes and coming out into the communities, into the hospitals and doctors' offices to try to do this work. So patients were clearly looking for a way to communicate and continue to get care from their medical providers in a way that but in a way that would keep them and their family safe. And at the same time, too, we were trying to make those changes internally as well, to keep patients, from sitting in waiting rooms in offices across the area, and to keep our folks as healthy as possible from a staff standpoint. So that's been that was sort of a main driver of moving telehealth for our organization. In addition, the medical staff's readiness to think about how we do telehealth certainly changed. So we've been talking about doing things like video visits for more than a few years, and I'll talk about that a little bit when we get into the e-care section here in a minute. But there wasn't, I would say, a lot of appetite from the medical staff standpoint, thinking about how they wanted to approach that. People had a lot of questions about, how does this affect my relationship with my patients as I see them? How am I going to take care of somebody when they're not in the same room with me and I can't examine them in the same way that I normally would? Am I going to pick up on all the both the verbal and nonverbal cues that patients give us, the general gestalt that we have when we try to determine if someone is sick or not sick? And so people had a lot of questions about how this is going to work, and that was even separate from things like, is the technology going to work when we want it to work? And the other big piece is, are we going to get paid for it? Are we going to get reimbursed for that time and that work that we do? And obviously, when we change from seeing lots of patients in our offices and clinics across the area to seeing very few, the interest in moving this forward ramped up greatly. And I think you saw a lot of our medical staff realize that they could provide very good care to patients from afar. I will say that from Maine General standpoint, most of the work that we did in the early days of COVID was entirely telephone based, and we can talk a little bit more about that either later in the presentation or during question and answer. But we did not feel that we were adequately set up for a video solution that was safe for our patients and us to use from a security standpoint, or the one that we felt that would be a great asset to us. And so we very much focused on taking care of patients over the phone, which is something that doctors have done for years. But obviously it was very different when you're sitting in your office in the middle of the day, having a list of patients in front of you to call and check in about their blood pressure or their diabetes, or to talk to them about symptoms that they're having and those kind of things. But the medical staff overall, I think we got very good results from people saying not only did they feel like this worked very well during the course of the COVID pandemic, which is still ongoing, but that they also said that this is likely to change their practice significantly in the future, and that there are many things that we actually could do a very good job with, even if we're not sitting in the same room with the patient. And in some cases, there were things that we could do even better. One particular area at Maine General that highlights this is our Edmond Urban Pediatric Center, which does both child psychiatry services and developmental pediatric evaluations. And a lot of their issues with evaluating the kids and adolescents that they take care of have to do with travel issues. Parents having a difficult time getting the kids in for visits, maybe having other kids at home that they have to worry about. Are they going to bring them in for the visit, or leave them with a family friend or another family member? And when they could move to telephone visits, they found that their no-show rates and late cancellation rates went to almost zero, because it was just so much easier for the physicians and the patients and their families to connect by phone and to have that be a meaningful interaction. So again, that kind of moved us forward in that medical staff readiness. The other thing that was also greatly changed during this time was the vendor capacity for telehealth. Prior to COVID, there certainly were a number of companies that were starting to offer televideo visits, but they were certainly not prepared for the onslaught of questions and groups that were really looking to move to this entirely. Some EMR platforms already had televideo capabilities built in. Ours did not readily have that available, so that wasn't an option for us. And there certainly were other new vendors that have come up over time. I don't think many of us really knew what Zoom was prior to COVID, and Zoom is now a major player in healthcare for these sort of visits. Unfortunately, there's a negative aspect to that as well, and Laura touched a little bit on this on her last slide, that there's a, there was a sense that, well, now that the pandemic is here and we're under critical conditions, we can just do whatever we want. I think a lot of people understood that, that there was suspensions to things like the, like HIPAA that said that we could use and do televideo visits with platforms that were not necessarily HIPAA compliant, or that would absolutely protect the confidentiality of the visit and the information. But even those changes were not ironclad, and people are suffering the repercussions of that now. But the biggest thing that we found is that when in some organizations, when they said basically just connect with your patients by video, however you want to do it. So get your own Zoom account or use your FaceTime on your phone or your iPad. What they found is that it's very hard to rein that back in once the regulations and the payment issues start to change. So we very deliberately did not take that approach. Again, focusing mostly on telephone visits and continuing our plan with ramping up televideo visits in the way that I'm going to describe next. The last big piece was the payer policies. Obviously, once the pandemic in the United States was announced, CMS immediately changed their policies for Medicare and Medicaid patients, saying that they would pay for telephone or televideo visits in a manner that was similar to how they were paying for visits that you had with your doctor in their office. Obviously, that was a big change for us, and many of the private payers took the same tack. Most of them, in our experience, did that on their own, realizing that that the patients in their plans needed to get care, and some were forced by state regulations and laws, changes in laws in the states. But what we're also finding now is that as the pandemic changes and we start to realize that there's a much longer process for this, that some payers are starting to back off on that and starting to set dates of saying, yes, we're going to pay for televideo visits, but we're not going to pay for telephone visits. And initially, some had said that they were going to start to lapse those as late as the end of July, which is obviously already passed, and they've pushed that back. But we're still seeing some payers that are talking about the end of September as their time frame for saying that they will no longer pay for telephone visits, and that they will pay for, and some will pay for video visits, but at a reduced price than what they would do for a reduced cost than what they would do for in-person visits. So there's still, I think, a lot that needs to come about from that, especially when you look at it at the macro level for a hospital system and the way that we go about, planning our budgets and those sort of things. We have to have a good sense if this is worthwhile to us to provide these services. Next slide. So this just gives a general overview of some of the efforts that we're taking at Maine General in telehealth. So the first thing I'm going to talk about is our virtual visits, which started in June in Express Care, and will eventually be rolling out into our primary care clinics as well. Then Laura will jump on to talk a little bit more about remote patient monitoring, which is a really exciting tool that we started using within the last year that has some implications for trying to keep patients with chronic illnesses safe at home. We'll talk a little bit about our patient portal, which is part of our electronic medical record and allows patients to have access to their own medical records and information to a certain degree, and really hopes to get us to an area in the future where patients have a truly portable record that they can take with them no matter where they live, no matter what hospital system or clinic they're going to see, and ultimately if they change payers and those sort of things as well. So, really trying to get to that ideal of the patient truly owning their medical record. We'll talk a little bit about our mobile patient experience and some of the things that we're starting to offer for patients in this area. And then also just recognizing here that Maine General, while we provide telehealth services, we're also end users of telehealth services. So there are areas that we are focusing on that help us that we get from other systems. So in particular, our emergency department and inpatient areas have partnered with Maine Medical Center and Maine Health to receive expert neurologic opinion when patients are coming in with a stroke. And that's done both through telephone and video links. And we also at our Harold Alfon Center for Cancer Care provide genetic counseling, again, partnered through Maine Health to provide that service for patients when they need it at our facility, but with a genetic counselor who's actually remote to this facility. Next slide. So in June, we launched our pilot for Maine General eCare. This actually well predates our work on COVID. So we had started planning this really well over a year ago, and we're looking at a way to start to provide patients with care where they were, and not saying we have to always follow the traditional model of coming in, registering, waiting in the waiting room, seeing your medical staff member, checking out and going on your way. And one of the reasons, honestly, that we did this is because we realized that there is a market for this, and if this care was going to be provided in our community, we wanted to be the ones to provide that. We wanted to provide that service to our patients and families in the community as best we could. And so we began looking for vendors to help us with this work, and eventually settled on one. And starting in June, we have a pilot, which is really just for Maine General employees and their families. That may seem like not a big pilot, but actually Maine General has over 4,000 employees, and when you add their families to that, it's a pretty big group that could potentially utilize this. And they are express care visits or urgent care visits that are delivered via video, and you can see the hours that we have provided there. Right now, it's all web-based, but soon there will be a mobile app so people can actually access this from their phones wherever they are. So being able to, again, get care for acute needs wherever they may be. Next slide. So this is just a little bit more information about it. The urgent visits are, again, fast, convenient care. They're available from your cell phone or computer, and there's no appointment needed. You just call in when you want, and you're connected. Hopefully, in most cases, with a Maine General provider, although the system that we're using does have the backup of utilizing someone else if we are not able to readily provide that care. And you can see a list there of the different types of conditions that people can be treated for virtually, and does not mean that all things can be evaluated in that way. And so in situations where it's felt like the patient's complaints may need more care, and they need to actually go to express care or primary care or the emergency department, then we certainly make arrangements to work with folks to get that done. Next slide. And this just gives you a sense of where we've come with this over the past couple months. We've, again, starting with the pilot, we've had 32 total visits. The average wait time to get into the visit is about 13 minutes, and the average visit time itself is pretty quick. Now, 12 minutes may not seem like a lot of time, but it's actually pretty analogous to what you would have for an inpatient, in-person visit in an express care clinic as well. So you can see that the overall numbers have been ramping up every week as our own employees are getting, more and more used to this and more aware of it. It's one of those things that you can send out recommendations for people to give this a try, but they need to have a reason to do so, and they need to be aware of it. They need to be signed in to be able to do it. So there's a learning curve with doing that sort of thing. And then we've also asked our employees who have used this, where would they have gone if they hadn't used Maine General eCare? And you'll find that most of them would have, not surprisingly, gone to urgent care or their primary care physician, but some would have delayed seeking care. And that's certainly not something that we want. And what we're also trying to do is avoid patients going to the emergency department for these sort of issues, which likely can be handled in other ways. Next slide. And I'm going to hand this over now to Laura to talk to you about the other areas.
And just one thing, thank you. One thing to add about the wait time, the average wait time there was 13 minutes. And that's actually with a few outliers where we were working through some technical provider notification setting. So that's one reason we started with the employee population, so they would give us more real-time, frank feedback, and it's been very helpful and very productive. So the true wait time without those outliers is much lower. So remote patient monitoring. Remote patient monitoring is a program that we partner with a vendor called Health Recovery Systems, HRS. And we launched this program in late January of 2020, pre-COVID. And the original intent was to help to reduce our readmissions, and with a beginning focus on patients with congestive heart failure. So patients who have remote patient monitoring services, it started typically with patients who were discharged from the hospital who had a diagnosis of CHF. We very quickly expanded, due to the pandemic, to any patient with a chronic or acute condition. That also changed as payer policy changed in response to COVID. So we now are accepting patients who are being discharged from the health system or who are referred by an outpatient practice who may be at increased risk of contracting COVID and would like to stay within their home, or perhaps not coming in for in-person visits as frequently. So what is remote patient monitoring? It is a patient receives a tablet and then Bluetooth enabled pulse oximeter, scale, and blood pressure cuff. And the tablet is secured so that it can only be used for this function, to have the patient, for example, step on the scale and it automatically pulls up their weight to the tablet and also transmits that information to our central remote patient monitoring office, where we have a nurse who Monday through Friday is monitoring for alerts. We have parameters set that are within normal range. And so each morning, our remote patient monitoring nurse logs in and tracks throughout the day. It will give a patient a green, yellow, or red indication if they either have not tracked their vitals for the day, had something that was questionable. They had, a 3-pound weight gain within a day. So if there are any alerts, they will reach out to that patient, call them on the phone and ask, oh, I forgot I was holding a glass of water when I stepped on the scale. If it's something that needs to be remeasured, they would help either ask them to remeasure or troubleshoot if there's an issue. If there is a true risk in the vital reading, the remote patient monitoring nurse reaches out to the primary care practice and asks if there needs to be any adjustment in medications or any other intervention that may be required. And at that time, collects the orders they may need to do so. There also are options within here to enter in times for medication reminders. And there are also risk survey questions. So those are assigned by diagnosis. So if a patient has CHF or COPD, they're clinical questions that are designed to help trigger if they may be at increased risk for that day and may need follow-up. We're running about a census of 50 patients, 50 to 60 patients at any given time. We have graduated a number of patients with a goal of 90 days on monitoring without an inpatient or ED visit. And if they, for some reason, do have a visit while they're on monitoring, that 90-day time frame resets. So we've seen over 100 patients, and we have a goal of having a census of about 100 patients by the end of this calendar year. We have learned a lot in terms of staffing and being able to make sure that we have home care patients and our remote patient monitoring team, making sure that the communication is working seamlessly and we're able to go to the homes to set up these units and make sure we pick up their units when the monitoring service is finished. So a large number of our patients are also open to home care services. And one thing that's been nice is after let's say they're discharged from the hospital, they're open to home care services. They have that for 30 days. after home care services need to come out, they can still have that remote patient monitoring unit and continue to be monitored in the comfort of their home without having all services kind of taken away at once. So it's been a nice transition. And we've had a number of patients who had a high risk reading, and they may have gone to the emergency room or something like that. But we had one instance of a 98-year-old woman who was one of our first patients on monitoring, and she answered the phone and said, "I knew you'd be calling." She knew that her reading was high, but she knew somebody was checking on her. And we found that just anecdotally, that's been big, is just to have someone they know is checking up on them. So for patient experience, that's been really valuable.
Laura, do you mind teasing that out a little bit? I think that's an interesting point. And with regards to what has the kind of the learning curve been for patients using the HRS? And likewise, as you know, our demographics trend older as well. So, what does that typically look like, or from a staffing perspective, what's the learning curve like for patients?
Sure. So we started this as a pilot as well. We started, the inpatient care manager was providing education to the patient and their caregiver upon discharge. And we very quickly found that patient getting discharged from the hospital has not only to collect all of their belongings when they leave, but to carry a remote patient monitoring unit out and remember their discharge instructions and how to use the unit was far too overwhelming. So we fairly quickly changed to, at least not the day of, but at least the day after, a few days after discharge, going to the patient's home. They'll be shown a demonstration of the unit while they're inpatient, but whether it's an inpatient or outpatient referral, someone goes to their home, sets up the unit, makes sure that the connectivity is working, they're able to track their first vitals, troubleshoot if not. We have, HRS provides patient IT technical assistance, so we're able to call them right then and there if needed. So that's been really valuable. And just from a staffing perspective now, we're making sure we're aligning the resources so we have that dedicated resource to go out to the homes, and then also be able to use our nurse to be at the satellite site monitoring those.
Thank you.
Sure. Next slide, please. So mobile patient experience, this is something that we have been working on, I want to say, for over a year now. This is kind of a suite of services, and this is part of Allscripts company, and it's called Follow My Health Enterprise, and they have kind of a suite of services. The first that we have rolled out is Save My Spot. So this is for our express care practices, and you can go onto the Maine General website and look up Save My Spot, and you can see the wait times for our 3 express care locations, so Augusta, Gardner, and Waterville. And you can see the wait times, and then you can also select a slot. So in person, you would go to express care, and then you wait to be seen in person, depending on how many other individuals are in the waiting room. With Save My Spot, you can see the wait time. You could look at the wait time and decide of the 3 locations which you'd like to go to, depending on where you are, or you can save a spot and be kind of first in line within that time frame when you get there. It's not guaranteed that's the time you'll be seen, but kind of allows you to move up the line, so to speak. The other thing we've been working on is appointment confirmation. So this is the ability to confirm appointments by text message. We're also in the future very close to rolling out that mobile check-in, so being able to register and check in and also pay your bill online. This entire mobile patient experience is one of those instances where it, on the surface, may be fairly simple, but to make sure that all of those things on the back end take place. Save My Spot, for example, is looking at the wait time and then selecting a spot, but that also needs to make sure it integrates with our registration system, that we can accurately be putting appointments in. And for mobile bill pay, for example, making sure that it's accurately showing that real-time balance for the patient. So a lot of things on the IT integration side that it's until that integration is fully in place, you know, that really dictates the timeline of when these things can be rolled out. So Follow My Health patient portal. This is something we've had for a number of years. The patient portal started initially, I believe, as CMS. It was originally called Meaningful Use, and then changed over the last couple of years to promoting interoperability. And part of the purpose of that was to increase patients' access to their medical information. And so we've had the Follow My Health patient portal, which provides 24/7 access to a medical record. Right now within our patient portal, you can request an appointment, see your lab results or immunizations. For me, you know, I have young kids, and being able to quickly log in and print off immunizations is incredibly convenient. You can also pay your bill through the patient portal or send a message to your provider. So if someone's at work and can't necessarily, it's not as simple just to jump on the phone and schedule an appointment, you can send a quick message through the patient portal and get an appointment scheduled that way. There's also a library of patient education information where you can look up a specific health condition and learn more from reliable sources, or request patient referrals. So we've had that for a number of years, and because we're also rolling out a new EMR here at Maine General, are not making any planned major updates and services to the patient portal, but we are continuing on with this service. So emerging trends, Dr. Dionne spoke to this in an earlier slide. Telehealth vendors have been strapped for resources. We have seen that firsthand. All telehealth vendors, you know, are really trying to meet the demand, and our virtual visit vendor is MD Live, and just based on our experience with MD Live, saw very quickly as COVID hit, you know, they have not had the resources that they had necessarily planned, or the capacity they planned on to be able to meet the needs of all of these health systems who are now rapidly looking for this service. Also, you know, in the virtual conferences we've attended recently, really hearing a lot about the importance of a digital front door, and what does that look like from a health system perspective, so that patients, at whatever digital device or however they're seeing a health system, what's the first place they see the health system, and how can they easily access our services, identify the right level of service, and give them choices to kind of help accurately steer them and show them the tier of services that may be most appropriate based on their needs. So that's something that's really up and coming as a trend. And patients are also starting to expect that touchless experience. You know, Target or Walmart to go, they have an app with the location enabled, so they know right when you pull up in the parking lot. And so patients are going to start looking for that same thing in healthcare, you know, to come into a waiting room and not have to touch anything necessarily, but to be able to be kind of pulled through that patient registration process, check in, and being able to see their medical staff member when they do come for an in-person visit, or being able to do it completely virtually. So we'll continue to see more of that from the patient side. Also really needing to monitor payer policy as it's changing. Dr. Dionne also alluded to this. As the public health emergency got extended, payers kind of extended their time frame for pulling back coverage, but it's something we need to very closely monitor as we consider whether we can charge a flat rate for these services versus billing insurance, and then which services we can financially sustain as well, and how we staff that. Behavioral health, this is just something that I heard at the American Telemedicine Association conference, is that behavioral health is really being looked at as something that could be better served virtually, and Dr. Dionne also alluded to this. And when you're offering that, not only does it help with the transportation issues, which is one major social determinant of health, but also being able to see into the patient's home and see, for the first time, care teams are able to see what's going on in the background and, can either see the chaos in their life or see what some of their needs may be and help link to care management services as needed that way. We're also going to see more mergers and acquisitions among larger telehealth companies. As these smaller companies may be struggling to meet the demand, we're envisioning seeing more. There have already been, just in the last couple of weeks, some major ones that have come in, so more mergers and acquisitions. And one other thing just to mention about going back to the e-care service, we've piloted with the employee population with plans to, after our mobile application goes live very quickly, we're hoping later this fall, roll out to the larger public. So there will be an express care virtual service as it is, as Dr. Dionne spoke to, but that will be open to the public. So anyone in our communities can access that service within our express care hours. So we will be sharing that more widely as we have timelines for when we'll be able to roll that out and more information. So stay tuned for ticklers on that. Next slide, please. I think that's it. Dr. Dionne, anything you want to add?
So I would just say we appreciate being able to speak to these issues and interested to hear if folks have any questions or comments or ideas and would like to further the conversation in any way.
Yeah, thank you. And for folks joining us right now, feel free to either unmute yourself or drop a question in the comments section. I guess I'll maybe pop in. And again, thank you so much to the Maine General team here. Really wonderful to hear. In particular, really wonderful to hear some of the foresight and leadership on having started some of these pilot programs and initiatives pre-COVID to really illustrate how we got here today and the exceptional medical care that's being delivered to Maine residents. So to that end, again, thank you. Doctor, you mentioned, physicians have been providing care over the phone for so long, as well as other medical professionals. And then we're in this moment of time that didn't start for COVID with regards to telematics and going virtual. On the flip side, how has this put an increased premium for those face-to-face meetings, the premium on touching that patient? And thus, how is it inversely affecting your inpatient care for patients that are coming into the hospital?
Yeah, it's a great question. I mean, certainly the effect of COVID has been widespread for us during the initial months of when patients were largely in their home. We still saw a fair amount of volume of patients coming in for care in places like the emergency department. It was in the primary care and specialty and express care clinics, it was much less so. And part of that was our own, really pushing people to not necessarily come in during those times. But when the emergency department, obviously that's, open 24/7 and people can come in at will. But even there, the volume in the emergency departments went down. And that clearly wasn't because people weren't getting sick. It was a combination of a couple of things. One was patients that just chose that because of the problem that they were having, they made the decision that they really didn't need to go to the emergency room. And we realized that we see things in the emergency room that could be seen in a primary care clinic or could be seen in express care or other places. But when somebody comes into the emergency department, we're required to see them and to take care of that issue. And so clearly there was some of that. And the others, unfortunately, were people that largely avoided care when they really did need to get care. And so I think all emergency departments have seen stories of people who have come in who have been sicker than they would have otherwise because they delayed the care that they needed to get. And that's one message that we're trying to get out there to patients now, to say we're taking many, many precautions in our emergency department, in the hospital, and all of our clinics to try to keep people safe when they come in to our facilities. And we don't want them delaying the care that they need to have. On the inpatient side, it was the same sort of thing. So obviously fewer people that come into the emergency department, there's fewer patients on the inpatient services as well. But the biggest thing that affected our inpatient services was also essentially stopping all non-urgent surgical and procedural care. So when people aren't coming in for knee replacements or hip replacements or having, routine, even things like mammograms and colonoscopies, those were things that would affect the overall census for us in the hospital as well. So it absolutely, changed our approach. Now, at Maine General, we are now back to providing all the services, albeit with a lot of different precautions. But every service that we provided before, we are back to providing now. And the hospital, the emergency department, our clinics have been quite busy, but they won't look as busy as they had in the past because of things like trying to get people out of the waiting rooms as quickly as possible, and trying to trying to do everything we can to keep our staff and to keep our patients and families healthy.
Great, thank you. With regards to, either rolling out the HRS or just in general telemedicine, and for Maine, we are a very diverse state, of course. Can you touch on any challenges or just the importance of broadband and good broadband connectivity for these initiatives? As in Maine and beyond, broadband's often referred to as the tale of two cities, or maybe in your urban locale, there's redundant good internet and fiber optics, but maybe in your more rural and hinterlands, very difficult, the last mile problem. How has that affected some of these initiatives, and have workarounds been substantive and positive?
Sure.
Laura, you want to take this one?
Yep. So for remote patient monitoring, we saw this challenge coming. And so one wonderful thing about our partnership with HRS is they provide all of the tablets with the SIM card. And so we're using Verizon SIM cards right now. And they have supplied all of that. And we really have had very limited issues with connectivity. There have been a few instances where, a patient lives out in the woods and they have a metal roof and we've had to put their unit close to the window. But other than that, we have not had any patients with remote patient monitoring who have not been able to connect due to those issues. On the virtual visit video side, because we've started with our own employee population, for the most part, it's been employees who are in the parking lot or in their office. We have seen a few instances where we can hear, but not the provider or medical staff member can hear, but not see the patient. The video is a little choppy. And the workaround right now is to quickly convert that to an audio only visit. So that's kind of been our workaround, and we're foreseeing that is going to come up more as we roll this service out to the public for virtual visits. We certainly see that as being an issue coming up, and I think there are a lot of statewide efforts to try and advocate for a greater broadband across the state and in more rural areas. So to the extent we can, we will try and have, anecdotal data on some of our challenges to help when those things come up, and opportunities to advocate for that as well.
Yeah, our catchment area here is mostly Kennebec and Somerset County, and so in our areas, I think we certainly run into that with some patients. We have talked about the idea for the virtual visits, express care visits, the idea of putting up kiosks in certain areas where people could potentially go to a kiosk to get virtual care. But it also, you think about, would you really want to set up a kiosk in an office where somebody could see somebody in person if they wanted to? So trying to think about the ways to do that, that would most be helpful to our community. But I think from a larger business standpoint, the importance of having a functional broadband capacity in our state is huge, and it speaks to the issue of how do we expand telehealth services in the future. It's one thing to be able to provide primary care or express care, but we also realize that there are huge swaths of Maine that don't have access to a lot of specialty care. And specialty care means getting in your car or having your neighbor pick you up and driving you sometimes hundreds of miles away to get the care that you need. And unfortunately, some of that care can be provided over a telephone or video visit, very functionally, that would save everybody a lot of time and money. And so ultimately being able to have these systems in place that will allow us in the future to have somebody, in more remote areas of the state, or even in areas like, I don't consider Augusta to be particularly remote, but there are certainly specialties that we don't have here that would be great to be able to provide to people remotely, whether they're sitting in their doctor's office, their primary care doctor's office, seeing a specialist, in another city, or sitting at home. I really think that has to be the drive for us to get to in the future.
Great, thank you. And we just have a comment that came in, Mr. Pitcher, saying thank you to the Maine General team on a job well done, and a comment kind of concurring with the broadband challenge, but also the challenge of a tech-savvy general public, which I think is a nice point on the user end of things.
And I think that's beholden on us as well. Things like that Laura was talking about with the remote patient monitoring. You have to build those systems so that people can use them, and also make sure that when you're teaching them how to use them, they're in the right frame of mind to be able to do that. I mean, when somebody's leaving the hospital, it's the time when we give them the most instruction. It's probably the worst time for people to be able to learn new things. And so I really like the way that they were able to pivot in that situation to get out to people's homes to help them, learn how to use it once they'd had a chance to sort of establish back in their homes and get back with their families and do those sort of things. That's what's really important, because there is no doubt that even for younger, more tech-savvy patients, there's a learning curve for this stuff. And for the older patients, it can be downright scary, but it doesn't mean it's something that they can't do. And I think we've been very successful in having people be able to maneuver that.
Another thing just to mention is, that older population, since COVID has hit, they're used to, it's not the same, but they're used to FaceTiming and Zooming with their grandkids. And so they have become more comfortable with that just in the last few months. We also very quickly learned, when we rolled out this virtual visit service to our employee population, that there were some key opportunities to provide patient education. So we will have that ready in those instructions and FAQs. One example is, we rolled the service out, and I received a call from someone who I was helping troubleshoot with, and realized, we need to be communicating and breaking it down even to, if you have a laptop but do not have a camera, and your laptop is docked in a workstation, and you do not have a camera on your monitor, your camera is not going to pull your video from your docked laptop. Those kind of things that, someone who's in it day to day may not think about, but not all patients think about that kind of thing. So this pilot has been really helpful in terms of giving us great talking points for patient education as well.
Great point, thank you. Mentioned in one of the slides some trends and some kind of future trends. At the macro level, and maybe as a country or a nation, where do you see some of those trends? And specifically, are we thinking about the importance of investments in immutable health records that patients can see, and some financial technology platforms to help with paying for that? Or is it robotics in terms of the delivery of some of that medicine, or is it both? And likewise, is there, thinking about Maine in that lens, is there a benefit to either one or both? And thinking we have island communities, rural communities, urban communities, would be interested to hear if you have any thoughts on that.
Oh boy, that's a big question, and I think it's a great. I mean, there's so much to unpack there, and so many areas to focus on. I have to be careful to say what I think will happen versus what I wish would happen. But I mean, there's no doubt that the changes that we've seen in our world in the last few months are going to lead to significant changes. It bothers me a little bit when we're only a few months in, to the COVID pandemic, and people are already talking about backing away from payment models and things like that. Because I really felt like and Laura, I think, can attest to this. there was so much positive energy around telehealth in the first few months of this. It was one of the few positive things that we could pull out of this. And then almost as quickly, there was discussion about starting to pull that back. And obviously the big player in that is CMS, and they have not said that. So Medicare, Medicaid, they are not saying that right now, that they have any plans on doing that. But obviously there's so many aspects of that can play into that. The government finances, outcomes of elections. There's so many things that can change the way that we approach, providing that care. But I think that's a big part of it. I mentioned it a little bit earlier, but I'll say it again. I think the idea of us moving to a patient record that the patients own is probably one of the single most important things that we could do for the healthcare of our country. When patients, leave to go from one area to another or one doctor's office to another, and they don't have access to things like their basic problem list and medication list, it's hard to provide any sort of coordinated quality care. And so being able to provide patients with tools that allows them to do that, but then also realizing that any individual health system can't do that. I mean, we can't provide that for people. It has to come from a national level to be able to say, we need to partner with big companies that will be able to safely protect people's data, but also give them a way to own their own medical records and own their own care in that way. And I think that's just a huge portion of it. We can certainly work on things like access to care and getting primary care and specialists and things like those that in the areas that they need. But we certainly need, the help both from the tech aspects of our economy as well as the government to help us to push this through. Laura, do you have any additional thoughts on that?
I would just say a couple of things. In terms of giving patients access to their data, I think CMS has tried to help move that along for promoting interoperability, requiring API connections be available for patients. I just think there's a long way to go for health systems and vendors to be ready to make that really valuable for patients. So I think it's moving in the right direction, but it seems like it's going to take time for everyone to get on the same page and make that really meaningful. And then also to your question about the challenges and emerging trends specific to Maine, now that things are virtual, it's not just about Maine. We can have a large telehealth vendor come in to our patient population completely electronically. And so we really need to make sure we're finding the right way to meet our patients' needs and connect with them and show them that if you want a virtual service, let it be us who provides it, because we're close to home. And you may want a virtual visit service, but you also may like to know that the person you saw is the person who also shops at your local grocery store. So trying to give patients that opportunity as well.
Great, thank you. Well, with that and not seeing any questions, would like to say thank you so much. Thank you to Maine General for joining us this afternoon. Thank you for folks watching now and for folks watching later. Again, we will have this slide deck and presentation on our website. Thank you to our sponsors this afternoon. Tech Night is the second Thursday of every month, and appreciate all of those that join us. So again, thank you so much. What a wonderful presentation. And I know in particular, really loved hearing from our medical experts about some of the foresight and implementation of some of these projects that have been occurring or occurring right now and will be so important in the future. So thank you to Maine General for everything you guys do in the community and joining us today.
You're welcome. Thank you for having us.
Thank you for having us.
Cheers, everybody. Thank you.
Take care.